Now let's learn from our young participant, Dr. Supriya SRIGANESH, the Executive Director, Leading Cataract and Refractive Surgeon at Netradhama's Super Speciality Eye Hospital, Bangalore. She is actively involved in research, training and education. She organizes programs like NERDS, iView and NZRSC. She is also a recipient of multiple national and international awards, including the Best Paper of the Session at APA-CRS 2024. In this video, Dr. Supriya will share how she achieves spectacle independence for her patients, walking us through the patient pathway towards advanced vision and enhanced post-surgical quality of life.
Hi, I'm Dr. Supriya SRIGANESH. I'm a consultant cataract and refractive surgeon at Netradhama Super Speciality Eye Hospital in Bangalore. I do about 2,000 cataract surgeries a year and 500 plus refractive surgeries a year. So Netradhama is a group of eye hospitals in South India, which was founded by Dr. SRIGANESH, our chairman and founder, 30 years back. Our motto is Shraddha hi Parama Gatihi. So Shraddha means dedication. So we're very dedicated to providing excellent surgical outcomes to our patients. So technology has always been our tradition. We are the first movers in bringing new technology to the country and to our practice. And we were the first NABH accredited eye hospital in India. The patients that we typically offer diffractive trifocals to are patients with a more active lifestyle, patients who do a lot of near activity as well, so patients who like reading a lot, people who like doing intermediate work on their computers or their laptops, long hours of screen time, patients who do a lot of sporting activity where they cannot wear spectacles, and generally patients who are highly motivated for spectacle freedom after surgery. A very important question to ask patients is about driving, and especially night driving. But with the differential light distribution lenses like the geometric plus pairing approach, we do find that on the subjective questionnaires, patients are much more comfortable with night driving at about 3 months. So when a patient visits Netradhama, we try to make the experience as seamless as possible. The first thing that is done is the biometry. It's very important to do the biometry first before any drops are applied and before any other tests are done, because we need a pristine tear film for accurate biometry. And this is very important in premium IOL practice. You need to learn your patients. You need to spend time with them, learning their activities, their lifestyle, their preferences, their personality. We have a questionnaire. Any patient with an astigmatism of more than 0.75, we implant toric lenses. So this also ensures that we have good refractive outcomes after the surgery. Another very important preoperative test that we do for all patients undergoing trifocal lenses is the angle alpha. Every patient needs to undergo a specular microscopy and a OCT macula. We also do a screening for topography. The biometer comes with an inbuilt CT or corneal topography. This is more like a screening. So on that screening, if there is any red flag, the patient undergoes a complete topographic scan to make sure that everything is okay and it's not an irregular cornea that we're operating on. Now, abrometry can be important in irregular corneas, especially post-LASIK eyes or post-refractive surgery eyes, where you really want to see how the light is behaving through that cornea. So once all the scans are done for the patient and you have all the patient data, this is directly transferred into a software where the surgeon does the surgical planning. So what we target is that the sphere should be within 0.25 diopters and the cylinder should be within 0.5 diopters. So for advanced IOLs, this is a very important target to hit. We have a system of rotating tables where the laser part of the cataract surgery is completed, and then the patient is moved to the assistant who prepares the eye before the cataract surgery, and then the patient is moved to the surgeon who performs the cataract surgery. So this way, the movement of the surgeon is minimal. The surgeon, the screen, the phaco system, everything is stationary, and the patient is coming to the surgeon very efficiently one by one. That all the surgeons at our practice have trained under Dr. SRIGANESH. So this training ensures that they have a certain surgical algorithm in mind. So how do you complete your surgery in a short time without being in a hurry. It's very important not to repeat certain steps multiple times. The less you touch tissue, the less inflammation you cause. So that is why it's important to complete the surgery in a certain frame of time. So for advanced IOLs, we do prefer using laser-assisted cataract surgery. This allows a very standardized overlap of the capsulotomy over the lens, and it allows a shrink wrap effect. And it provides a more standardized effective lens position as well, which is not very predictable in certain cases. However, when you're doing a manual capsulotomy, you can also get an excellent outcome provided you have the right surgical technique and experience to get the standardization of the capsulotomy right every time. So if it's a very reproducible capsulotomy, even when done manually and when done in the right manner, it can provide a very similar effect as laser cataract surgery. For very soft cataracts, I prefer a mechanical chop technique. This is where I don't use any vacuum or phaco energy while doing the chop, and this allows for a safer surgery. The instruments come together and separate the soft lens, and it's easily aspirated. In a lot of ways, standardization included, preloaded IOLs are the way to go. So the multi-cert injector from Hoya is one of the most versatile injectors I've ever used. It's so easy to use, it's extremely smooth. You can use it either as a push type injector or a screw type injector, but I really prefer using the push type option because it does give me a lot of control. It's never gone in too fast. It is very smooth while injecting. And the beauty of it is the nozzle itself. So they have a beveled nozzle. What I do is I generally insert the nozzle all the way in because I like putting the IOL directly into the bag. When you have a cartridge that so easily fits into an incision without distorting the incision, causing any folds in the cornea, then not only is it very comfortable for the surgeon, it's comfortable for the patient intraop as well. You don't need to give them additional instructions to keep looking at the light. You don't need to force them. An assistant doesn't need to adjust the position of the eyeball. Everything fits, it goes in very smoothly, and it gives you excellent control. Also, for a post-operative refractive outcome and post-op recovery, it doesn't distort the lip of the wound. So this is really important in astigmatism control, where you're trying to give a good astigmatic outcome to your patient as well. Of course, in a 2.2 incision, it doesn't matter much, but the distortion of the wound, the folds on the cornea, all these are subtle small things that really matter in advanced IOL surgery. So in the geometric lens, more light is distributed for distance vision. About 50% of the light is distributed for distance vision and less light is distributed for intermediate and near. But in the geometric plus lens, about 36% of light is distributed for distance and more of the light is distributed for intermediate and near. So this is a differential light distribution approach where even high myopes can have excellent near vision. So patients have better intermediate and near vision with this pairing approach because light is distributed well enough for intermediate and near vision as well. So this pairing approach has really given us excellent outcomes in terms of quality of vision, even with the diffractive trifocal IOL. Outcomes as good as 92% of our patients are within 0.5 diopters of a spherical equivalent. So today we're seeing a lot of changing trends and growing demands for spectacle independence. And thank you for coming and taking a glimpse into our practice to see how we meet these demands. I hope these little tips were really helpful for you, and I hope more and more surgeons transition to an advanced IOL practice to give your patients the best possible outcomes.
So I think this is for Supriya and Eric both, and Supriya, you choose to use two complementary geometric IOL designs contralaterally. The first question is whether you also do it simultaneously or sequentially, and how does this compare to other trifocal options that you have used also?
So, ma'am, in our practice, we do it sequentially, not simultaneously for most patients. Of course, for a few patients, in special situations, we can offer simultaneous procedures, but our standard practice is to do it sequentially, maybe after 2 to 3 days. And like Dr. Ganesh said, the first eye, we always implant the geometric lens, which has better light distribution for distance. And the second eye, we implant the geometric plus. Now, how is this different from traditional trifocal lenses? In any other lens, trifocal lens, the light distribution is similar in both the eyes. So in both eyes, more light is distributed for distance, which gives you a little lower quality of vision in terms of contrast, brightness, and quality of vision for intermediate and near. So this is where this pairing approach comes in, and you have a fairly well-distributed light pattern for all distances. So patients are more comfortable even for near work and intermediate work with these lenses. And of course, night vision is also better because it's in that 3.2 millimeter zone in the center. The diffractive rings are only in that zone.
So I think as far as the role of diagnostics is concerned in patient satisfaction, Eric highlighted very well. Eric, I have this question for you. How do high volume surgeons ensure the reproducibility in results?
The thing is, the pre-op diagnostics, as was also pointed out by Supriya, is extremely important. You have to do all tests before surgery and for all patients, taking great care in doing the IOL master or a biometer as the first measurement ever, because when you have dry eye and you measure the decay readings, in many cases you end up with a fault measurement of decay readings. So also comes into play is we do in all patients all corneal topography, and we take a look at the epithelial thickness map. When we see an abnormal non-invasive break-up time or abnormal epithelial thickness map, we do not trust the measurements with our biometer. We treat the ocular surface and we let the patient come in 4 to 6 weeks later. I have a lot of patients showing half a diopter or more difference in between those two visits. So meaning, as was pointed out earlier, that you need to be within half a diopter of sphere and half a diopter of the astigmatism to have satisfied customers, satisfied patients, and good refractive results. So for all patients, do all measurements, so meaning corneal workout, biometer, dry eye testing, and also looking at the retina, of course, to have a full vision of that eye before you will do a full range of focus IOL implantation, and also order those lenses to get a consistent result. By doing that, we reduced our retreatment rate from 11% to nowadays 3%. We still have retreatments, of course, because there is no perfection in our world. Medicine stays medicine. It's not an exact science. So, but we reduced from 11% to 3%, which is for us a huge step forward in our patient satisfaction scores.